ook met internet. So, good afternoon. I'd like to thank the organization SenseAge, but I guess also ICEBI for the invitation and the opportunity for me to present my work. Well, it's not only my work, it's the work of a group I'm working in. I will present them to you later on. My name is Ruth van Nispen. I have a background in psychology and epidemiology, and I work in the Department of Ophthalmology at the VU University Medical Center in Amsterdam. And I'm a senior researcher, so I'm helping other researchers to write their thesis, PhD candidates, students. So it's really interesting. Well, we don't do this work all alone, I told you already. In all the research we do, we work really close together with Royal Physio, Bartimeus and Lindensdorf, Licht en Liefde, Blind Care, Light and Love from Belgium and the Netherlands. So let's get started. It is estimated by the World Health Organization that in Europe, where you see the green arrow above, that about 32,000 per million people are visually impaired in Europe. And this is comparable to Africa, for example, the Southern Americas, so these two, but also the West Pacific region, excluding China. But it's a lot less than in India, for example, or China. So this is some estimations just so you know what the amount of people have a visual impairment. In Europe, we seem to be a bit low on blindness. It's 3,000 on a million people compared to the other countries. Of course, if you look at the absolute numbers, there are 285 million people worldwide who have a visual impairment. And in Europe, 10% of them live in Europe. So 25.5 million people have low vision. So they have a visual acuity of lower than 0.3, and their visual field is smaller than 20 degrees. And almost 3 million people are blind. You might know that 65% of the people who have visual impairment are 50 years or older, so it's really an aging problem. And worldwide, uncorrected refractive errors and cataracts are the main causes of vision loss. But in developed countries, such as Europe and America, for example, there are increasing numbers of people having a visual impairment due to demographic aging. The common causes in the Western world are age-related degeneration, diabetic retinopathy, cataract, and glaucoma. In a study I did some years ago, I compared visually impaired people in older age. They had a mean age of 70, 80 years. I compared them to visually impaired adults who were staying at an inpatient rehabilitation center in the Netherlands. It's called Physio Go Air. You might know that center. The director is here in the back. And I compared them to the Dutch elderly. The burden of visual impairment in the elderly is really shown here. So many life domains are hampered, such as mobility. You can see here on the left, the red bars, that visually impaired elderly have much more problems with mobility compared to the younger adults and compared to the Dutch elderly general population. Same goes for self-care. There are many more people who indicate to have problems. Also, usual activities are kind of problematic, but the difference between the visually impaired adults is smaller. Pain and discomfort, there's a difference, but also, well, the difference is not that large. And then you see in the last bars that about 40 to 45% indicate they have problems with depression and anxiety. And the difference between the younger adults and older adults are not that, well, there's almost no difference, but you see a big difference between the visually impaired patients and Dutch only, the general population, in the age range of 70 and 79 years. Just to have some impression how the problems are. Well, what am I going to talk to you about today? I already started the story, but I want to discuss the problem of depression and anxiety with you. And first, I'd like to give you some definitions and epidemiology from the general population. After that, I will show you results from 2 studies we did. One we did in the general population, another one in a rehabilitation setting. And finally, I'd like to discuss with you what to do about people who have depression and anxiety in the visually impaired older adults. Well, many older people say, well, to have worries or to feel down is part of growing old. But let me assure you, depression and anxiety are not normal reactions to growing older, or it's not a normal reaction to having a visual impairment. Another thing you have to know is that depression and anxiety may hamper rehabilitation. People may have concentration problems due to depression or anxiety. They may have cognitive problems, so they have difficulty in information processing, which you need in order to rehabilitate. People may have motivation problems. People don't want to go further, they don't want to get better. So it's difficult for them to achieve goals. What is a depression? I'm not sure if everybody knows the criteria for depressive disorder, so I just shortly sum them up. When someone has a depressive episode, according to the DSM criteria, DSM stands for the handbook which is used by psychologists and psychiatrists to set a diagnosis. When someone has a depressive episode, it means that someone has, for more than 2 weeks, most part of the day, nearly every day at least one of the 2 core symptoms, which is 1, a depressed mood, or 2, a loss of interest or inability to enjoy all activities or almost all activities. In addition, in order to meet the criteria for depressive episodes, one has more problems than that. So at least 4 of the list which is shown below. So it may be weight or appetite problems, sleeping problems, psychomotor, agitation or inhibition. So that means someone is really active or really slow and can't move, can't get up from the couch, for example. Fatigue, loss of energy, feelings of worthlessness and guilt, concentration problems, indecisiveness. Some have thoughts of death or thoughts of suicide, or some even attempt to commit suicide. So it's quite serious. There's also another mood disorder which is quite common but not so known. This is called the dysthymic disorder, which has the same cognitive and physical symptoms, but they are less severe, but they last longer. For more than 2 years people may have these symptoms. And the burden of dysthymia is similar to having a depressive episode. We were also going to talk about anxiety, so I will show you just shortly some anxiety disorders which are written down in the DSM, in the handbook. The common one is a generalized anxiety disorder. This means that one would have over 6 months excessive, uncontrollable, irrational worry about everyday things that is disproportionate to the actual source of worry. So people may just worry all the time about everything. Social anxiety disorder, this used to be called social phobia as well, but we moved to another version of the DSM, and now it is described as social anxiety disorder. This means that someone has an intense fear in various social situations, causing considerable distress and impaired ability to function, at least on parts of life. So people may be scared to go to a place like this, for example. Panic disorder. This may happen in people who have recurring severe panic attacks, and sometimes this includes behavioral changes, which may last for over a month, and people may have ongoing worry about the implications or concern about having other attacks. So people start to avoid going to places. And agoraphobia, you may have heard of that. It's being afraid of large spaces or squares or things like that. So this is an anxiety disorder as well. And people may have a fear of having a panic attack in situations where certain environments are perceived as dangerous or uncomfortable due to the environment's vast openness or crowded places. And some people just stay at home because they're just afraid to go outside. And even the thought of going to a place may hamper them and keep them at home. How do we measure these disorders? I thought I would, I wanted to show you a little bit how we would measure this in research. We use many different questionnaires. And an example of such questionnaire to assess a disorder would be the MIDI International Neuropsychiatric Interview. And questions we would ask are, for example, have you ever felt depressed or down for more than 2 weeks, every day and during most part of the day? So people can indicate yes or no. And if this would be yes, then you would ask all other symptoms, but also excluded symptoms. For example, if someone has these symptoms because of alcohol abuse or because of loss of a partner, because of grief, then you wouldn't say this person has a depressive episode, but this is because of other reasons. A current disorder, we would ask, during the past 2 weeks, did you feel depressed or down every day and during most part of the day? And many other questions would follow. For example, to assess generalized anxiety disorder, we would use, in the past 6 months, did you worry excessively or did you feel anxious about certain issues? And did you feel that way most of the days? This is just an example question. We also do assess depressive symptoms. And it's a bit of a quick and dirty method, because after this you don't know if someone has a depressive disorder, you just know if someone has symptoms. Examples would be, I was bothered by things that usually don't bother me, or I did not feel like eating, my appetite was poor. I felt that I could not shake off the blues even with help from my family or friends. These are just some examples, and you can hear that the symptoms of a disorder are in there, but we can't really say if someone is meeting the criteria of a depressive disorder. And the last one, anxiety symptoms. An example would be the hospital anxiety depression scale, the anxiety subscale. Question would be, I feel tense or wound up. I get a sort of frightened feeling as if something bad is about to happen. Worrying thoughts go through my mind. Questions like that. And we do assess something else. We make a cutoff score which says someone has significant depressive symptoms or significant anxiety symptoms. With the mini scale, which we use, it may take half an hour or even more to assess if someone has a depressive disorder or an anxiety disorder. Well, I looked up some studies because I wanted to know, is it really common in general populations to find symptoms of depression, for example, or depressive disorders? And I found that in a systematic review by Bakeman, that 10 to 15% of the population has depressive symptoms. And we call that subthreshold because they don't meet the criteria for depressive disorder yet. And depressive disorder is in the general population 0.6 to 3% of general populations, and these are combined data from different studies in different countries. For anxiety, this was a more recent study in 2008 by Bryant. He found in one study, there was only one study in a subpopulation of 78 years people and older, and 24% had symptoms of anxiety. And anxiety disorder was found in different studies, and the range was quite broad, so 1.2 to 14% have an anxiety disorder in the general population. So why focus on symptoms and not on disorders? Do you have any idea? Someone?
Maybe you can, that they are not going to get the real depression when you see the symptoms and do something about it.
Yes, that's a really good reason, yeah. So you might be afraid that someone will develop a real disorder if someone has symptoms. This is actually true. There are more reasons. Having symptoms already have a serious impact on quality of life. This is studied in various studies. And like the woman said in the back, symptoms are the most important predictors for the development of depression or anxiety disorders. So you might want to do something about the symptoms because you don't want that your patients will develop a real disorder. And this was found, for example, in a Dutch study by Nelke van Veer. She used to work at our hospital. And she found that without intervention, 40% developed a disorder. So, and if you would intervene, then you could prevent people from developing the disorder. I will tell you later about that. People with symptoms already use more healthcare. And there's more comorbidity and mortality. People are less healthy. And another important reason, or maybe a result from this, in visually impaired older adults, depression and anxiety is highly prevalent. 1 in 3 of our patients have depressive or anxiety symptoms. So I would like to move to the studies we did. The first one was a general population study. And our goal was to compare the prevalence of subthreshold depression, so having depressive symptoms, between persons with vision loss and normal vision. And this was in the Dutch general population. And we also wanted to know with which factors subthreshold depression was associated in the general population, and if visual impairment would play a role. Is that a reason for being depressed? We used data from the longitudinal aging study Amsterdam, and this is really a large study, and it's an ongoing cohort study since 1992. And they studied the predictors and consequences of aging on the well-being and independence of older adults. And with older adults, we mean adults who are 55 years or older. Every 3 years, there are measurements on all kinds of physical, emotional, cognitive, and social functioning variables. In 1992, almost 4,000 persons were invited in this study, and over 3,000 decided to participate. And participants were recruited from all different areas, urban and rural areas in the Netherlands. In 2001, for the first time, we decided to do also visual acuity measurements. Because before we just asked if people had a visual impairment or not, just by doing a question, but now we really wanted to know what was their visual acuity. And for that we used the column from the 1 meter chart, because the trained nurses would go to the participants' homes and they would take the chart with them, so it was kind of a practical option. After that, after all data were collected, we defined normal visual acuity as a visual acuity of 0.5 and higher, and vision loss was defined as having 0.5 or less. And in between 0.3 and 0.5, we would say someone would have a mild vision loss, and below 0.3, someone would have severe vision loss. In this table, you can see that on the right side, you would see that persons, there are 102 persons with vision loss, with visual acuity below 0.5. And these people are significantly older. They were 81 compared to the normal vision group, who was almost 75. There were more differences. The visually impaired people were less often living together with a partner, probably because they were older. And they had more comorbidity, almost 2 other diseases in addition to their eye disease. And they had more cognitive issues, cognitive problems. I tried to split up the groups in 3, and I did that. And I saw that in the normal vision group, on the left bar, only 14% had clinically significant depressive symptoms. And if you look at the middle bar, the mild vision loss group, 23% had depressive symptoms. And in the severe vision loss group, 40% had depressive symptoms. And if you would take the vision loss groups together, around 27% would have depressive symptoms, because the severe vision loss group is quite small. It's only 25 people. Well, it looked like an upward trend, this graph I showed you. And this is also reflected in the regression analysis I did. Because here it says people with a visual acuity lower than 0.5, so the people with vision loss have more depressive symptoms. So they have almost 3 points more depressive symptoms on the scale we use. However, when we correct our model for other factors like having chronic conditions, cognition issues, living together with a partner or female gender, well, this was the end model. I tried out many other variables. Then you would see that the last variables are more important for the depressive symptoms than the vision loss. So vision loss was not significantly related to having a depression. So my conclusion was depression doesn't seem to be associated with vision loss, but more with other variables. Being female, living alone, having comorbidity, and cognitive problems. However, visually impaired patient groups in hospitals and rehabilitation settings are vulnerable. They're older, they have more issues, so you will find more depression. There are some limitations to the LASA study for obtaining knowledge on psychosocial issues in the visually impaired. The sample was quite small. We only had 25 people with severe vision loss, according to the criteria of the World Health Organization. So I couldn't confirm really the model. So this was a good reason to start a new study. So I'd like to show you a study we did within a population of visually impaired patients. And our goal was quite similar to the LASA study. So we wanted to know the prevalence and severity of depressive symptoms in visually impaired older adults over 50 years in the Netherlands and Belgium. And we also wanted to find out which factors would be associated to depression. Why would some visually impaired people have depressive symptoms and the others not? What is the difference between them? We started the study in 2009 and we finished including patients in 2011 in the Netherlands and Belgium, and we worked together, like I said before, with Bartimeus, Royal Physio and the Blindenzorg Liefde. The inclusion criteria were people had to be over 50 years, cognitively able to answer questions, and they had to understand Dutch or Flemish, which is the language of Belgium, the Dutch-speaking part. It was a measurement at one moment, so it was a cross-sectional design. We did interviews at the client's home or at the patient's home. This was done by medical and psychology students in the Netherlands and by occupational therapy students in Belgium. And me and my colleague, we trained them all. This was really nice to do. It was a adaptive face-to-face interview. So we entered the data immediately in the computer so we could use the data immediately as well. It took about 1.5 hours. Sometimes, well, I heard one student was about 4 hours with one patient. We always have that. Some people just like to talk about their lives and, you know, so you can't, you have to go back to the questionnaires again. And we used some standardized validated questionnaires such as the CSD for depressive symptoms, the CD, which we use for depressive disorder, adaptation to age-related vision loss, maybe familiar to some people. We assessed coping with the 30 mastery skill, ADL, activities of daily living, cognition with the MSE, health indicators such as the Eurocall or culpability, and all kinds of social demographic characteristics. Just some characteristics. We interviewed 384 patients. Almost 60% was female, and the mean age was almost 78, and the youngest one was 52 years old, and the oldest one was 99, almost 100. 48% was living alone. Mean years of education was about 10 years. Some people, well, quite a lot of people, had strong or severe financial problems. We asked about religious belief. 50% had some kind of religion or worldview. 71% had a life event in the past year. This could be loss of a partner, disease of themselves or of a partner, really life events that would hurt them personally. Youth trauma, we asked, family psychiatric disorders, lifetime depressive disorder. This was all about a quarter of the patients. 56% had macular degeneration, and the others had all different kinds of other diseases, glaucoma, retinitis pigmentosa. You think of it. And 81% had comorbidity. So just to give you the impression of what we asked and the distribution of these patients group. And also, we wanted to know the relation between these characteristics and depression. What we found in our visually impaired population that in the Netherlands 29% have depressive symptoms and in Belgium 25%. So people are slightly happier there. The incidence of depressive disorder was in the Netherlands 6% and in Belgium 5%. If we compare these numbers to other studies, you can see we're somewhere in the middle. So Belgium 25%, Netherlands 29%, Leicester study, general population 27%. Well, this is Greece. This is an Australian study among people with low vision. 42% had depressive symptoms. Well, it's all about 1 in 3, somewhere there. These differences between studies may be real, but it could also be that there's some selection bias. So, well, maybe some populations are more prone to depression, for example. Other reasons may be that different criteria were used, different questionnaires were used with different criteria. So this may be the reason why there's a difference. Well, now we'll start with the complicated parts because I tried to make a model. I tried to find out which characteristics, which variables were related to depression. And first I wanted to know if depression would be related by variables that could be influenced by rehabilitation centers, for example, or by hospitals or individual workers. So these variables I investigated were coping, so being able to relate with stress, adaptation to vision loss, activities of daily living. This would be something occupational therapists would work on, for example. Mobility trainers would work on mobility, and reading would be done by a vision specialist, for example. So I wanted to find out if there was a relation between these variables and depressive symptoms. And if you could influence these variables, mediators I call them, you maybe could be able to get the depression down as well. Of course, there are many other variables described in the literature as well that would be possible variables that could influence depression. So I tried to see if there would be a relation between these characteristics and the mediators, so the variables that would be influenced by rehabilitation centers, for example. But also I wanted to know if there was a direct relation between these characteristics and the depressive symptoms. Can you still follow what I'm saying?
Yes.
Yes? Okay. Yes. So I immediately go to results now. This is going to be also a bit complicated because I found that some characteristics were related to coping. I'm not going to name them, just forget about this, but just that you know there are many relations between the variables. There were also relations between adaptation to vision loss and patient characteristics. Also activities of daily living and some characteristics. And finally, mobility also had some relations with characteristics. But also, there were some direct relations with characteristics of patients and depressive symptoms. And this is the depression path. So what I found was indeed variables that could be influenced by rehabilitation centers were related to depressive symptoms. So I would guess if you would work on coping, for example, with your patients, adaptation to vision loss, so acceptance of vision loss, and activities of daily living, this might lower the depressive symptoms. There were also some relations which you can't influence. Gender, for example, women always have more complaints. Youth trauma, you can't change that. If someone has a youth trauma, this would be a direct relation to depressive symptoms. And lifetime depression as well. I'm not sure what you're going to have to do about that. You can't influence it. I don't know if people would like to discuss that. Maybe it's not necessary at all. Maybe you should just focus on the things you can influence. So, first of all, I have some bad news because also in the Netherlands and in Belgium, and similar in all kinds of countries around the world, depressive symptoms are highly prevalent. So we found between 25 and 29%, and in international studies it's 22 to 42%, versus 10 to 15% in the general population. So it's at least twice as much. And if we look at the disorders, we found that 5 to 6% have a depressive disorder, versus 0.5 to 3% in the general population. Again, at least 2 times more often. The associated factors for example, gender and female, well, you can't change that, but there's also some good news. Loss of independence, in the sense of activities of daily living, for example, and coping with stress and vision loss, these may be some things you can change as an institution. And some things I found back in the literature, this was confirmed by other studies, also by the study I showed you before, so cognition, living alone, comorbidity. longer relates to depression in the general population study, but gender as well.
Can we take photos?
Yes, go ahead. I don't mind. I have to hurry to publish my work. It's a good pressure for me to publish.
Yes.
Yeah. ADL was confirmed by Evans, and Horowitz and colleagues found that multidisciplinary rehabilitation, such as prescribing optical aids, doing counseling and skills training, had a small effect. Well, there was an effect. It was a small effect on depressive symptoms. So, what to do about depression and anxiety in visually impaired older adults? After these data were ready, we talked with a group of psychologists and social workers to find out how can we improve what we're doing. And we spoke about collaborative care, for example, which means that you could work together as a psychologist or social worker and occupational therapist, that you don't have your own separate paths, but that you cooperate, make it really a multidisciplinary team. Improve screening. Maybe we have to screen our patients. I'm not sure about that. I would like to know what you think of that in a minute. Improve recognition of symptoms by all your workers in your rehabilitation center or institution. Offering peer support. Long-term monitoring, that you don't just give your patient an optical aid and send them home, but that you keep them inside, because you have to think about these patients have a chronic illness. They can't get rid of the visual impairment anymore, so why not keep them inside? And we talked about the depression and anxiety protocol, the stepped care protocol. There is some evidence already for treatment, but there are also some ongoing studies. The first one is the DEPFIT study in the UK by Thomas Margray and colleagues. And they are comparing 3 arms, so they're comparing 3 groups. One group is sent to the GP, one group is being offered problem-solving treatment, and the other group is on a waiting list. And they want to find out what's the best care for these patients. Then there is the IFAMD study by Ruth and colleagues in the United States. And he has a group that's offered counseling compared to a group that's just getting attention by workers. So it's kind of an enhanced control group. And they just published in 2011 their protocol, but I haven't found any results yet of their study. And we in the Netherlands at the VU University Medical Center, we're doing a stepped care study in the visually impaired. There's also some evidence already published some years ago. And the first one is randomized controlled trial by Brody and colleagues. And they investigated a self-management program for treatment of emotional problems and for improving self-management of visually impaired older adults. And their intervention was 12 hours for 6 weeks, and it took place in the Department of Ophthalmology. And their intervention had cognitive and behavioral elements, health education about macular degeneration and other services. And it was about improving problem-solving skills, focused on vision loss. And they had 32 patients in the trial, all with macular degeneration. And 12 people received the treatment, and the other group, 20 patients, received nothing. They were on the waiting list. And they found this was effective in lowering depression after 6 months. Another larger trial by Rovner and colleagues, they offered problem-solving treatment to prevent depressive disorder. And their intervention was this problem-solving treatment, and this would be about lowering negative perceptions that would interfere with problem-solving skills. And the intervention was 6 times in 8 weeks. And problem-solving treatment, do you know what it is? Have you heard of that?
Yeah. Is
Yeah?
it like CBT techniques?
Yes, cognitive behavioral therapy. It's something like that. So you would define a problem. So one maybe would be afraid to go outside, and then you would ask the patient, what is so scary, and where are you afraid of? Where don't you want to go? And maybe it's just the bakery around the corner. So you make the problem smaller. You break the problem down. This is a little bit behind the PST. So you set realistic goals with the patient, and the patient, him or herself, generates solutions, and he could pick his own solution and implement it. And afterwards you would evaluate the outcomes. The control group was usual care. They had 206 macular degeneration patients in their group. They found that the 2-month incidence of depressive disorder diminished with half. So they found after PST, after problem-solving treatment, 9 patients still developed a depressive disorder compared to 23 in control group. So that was quite a good result. However, this effect didn't last after 6 months. So you would have a short-term effect, but then it would come back again. And they recommended to address rehabilitation skills and booster sessions. This might improve the results. Something like just keep your patient inside, and I told you. There might be some new evidence coming up, at least I hope so, because I'm involved in this study very closely. This is a randomized control trial again, and the care provided has different levels of intensity. And previous research has shown that effects are supposed to last longer. And we developed this protocol in 2012 with use of focus groups with patients and professionals. How many times do I have? So the STEP care protocol. Well, you start with doing nothing. So a patient would have depressive or anxiety symptoms, and then you would tell the patient, well, first we just wait and see. Watchful waiting, because you also tell your patient you can call whenever it gets worse or whatever. You can make arrangements like that. But it is shown in the literature that if you wait and see, some people just improve, because if you measure depression once, it doesn't mean that you will find it the next time again. However, after 3 months, if the depressive symptoms have not lowered, we will move to the next step, which is a self-help book, which we call Cleanse at Your Depression. This is the name of the book. And it is based on existing material, which was developed in Amsterdam as well, at my university, but we improved it for visually impaired patients. And it's really a self-help book, so people can read it, or listen to it, or use Braille, or read on it, let it read by the computer. So we have different versions. And it is guided self-help. So an occupational therapist from one of the rehabilitation centers in the Netherlands would help this patient to go through the book, and just with some limited sessions. So an occupational therapist would introduce the book and would try to motivate the patients to start working with this book to improve the complaints. If this doesn't work, we move to the next step, and we well, again, we use some more intensive treatment, problem-solving treatments. Psychologists or social workers. Finally, after 9 months, then, if this doesn't work, then a patient could have symptoms for quite a long time. So then we say we revert refer the patients to a general practitioner. Maybe someone needs to see a psychiatrist, maybe someone would need medication. So this is the way it goes. So you see there's some time. There are different steps, there are 4 steps in the program. And there's different levels of intensity. So the care gets more intense. Once you move to the next step, you get more care. And it's also more expensive. The relevance, well, this has never been investigated before in visually impaired populations. Other study groups have investigated in general populations or general practitioner populations, for example, and have found good results, even in older adults. First we thought, what about the self-help group? This is nothing for older adults. How are they going to read that? But it's proven that it works. Because we developed the protocol and we're testing it out now, we plan to have an evidence-based protocol. And an important thing is that we prevent over and under treatment. And only in your countries, but in the Netherlands, there are 1 million people out of 17 million inhabitants who are on antidepressants. So there's a lot of over-treatment in medication in the Netherlands. Preventing maybe better than trying to cure, because one of the goals is to prevent the development of disorders. And symptoms of depression and anxiety are often not recognized in care settings, and often there are not enough treatment possibilities available. So this would be, I think, kind of easy to get your patients in. It starts really with a low profile, and then you move up to more intense care. So the goal of this STEP care program is to diminish symptoms of depression and anxiety. And the important thing is that we want to prevent that depression and anxiety disorders are developed. And this is called indicated prevention. And we also want this to be a cost-effective program because, this is what we have to show the world, that this is better than doing nothing, for example. This is our study design. We have 230 patients. We're almost there. We started in 2012. And patients are randomized. So it's like you throw a dice and then you say this patient goes in one group and the other one goes to the control group. And patients don't know themselves before they start the study. So they first have a consent form and they said, yes, I want to be part of the study. And then they know that they can be in the control group, but they accept that. So we have a step care intervention and a usual care intervention. So if someone is in a control group and he needs to go to a general practitioner for whatever reason, he can go there. It's no problem, because this would happen in the intervention group as well. Then we will have measurements at 0, before the intervention, 3 months later, 6 months later, 9 and 12 months later. And we also want to know about the long-term effects. So also about after 1.5 and 2 years, we will measure if patients have developed depressive or anxiety disorders. And now we are at the 6 months measurement, and some patients have already followed the self-help guide. I can't tell you this because it's still confined, but it seems that the self-help is really preventing patients from developing a depressive disorder or an anxiety disorder. So we're really confident that this is going to work. But it's not the final results yet, so maybe I'm a bit too fast now. In order to have these 230 patients, we invited many patients to be part of this study. 2,500 letters were sent to patients from organizations in the Netherlands and Belgium. And 780, well now we're already a bit higher, about 800 I guess, we screened with various questionnaires. Is this clear? Not clear? So, I'll just show you what it's about. So, 60% again are female, 40% male. Most of them are Dutch, 90%, and about 10% Belgian or other nationalities. The mean age is 74 almost. Years of education, about 10. Income level we asked, usually enough money, about half of the group. 94% still lives independently, so this gives you an impression of the group. They're not in nursing homes, or at least not so much. 6% is in a nursing home. Again, 46% has macular degeneration, and the others have other eye diseases. The mean number of chronic disorders is 1. And we found that 60% had no symptoms of depression and anxiety. 24% had depressive or anxiety symptoms, and 16% had already a disorder. And this is quite new because many study groups around the world are really focusing on depression. And since anxiety and depression are related, we don't focus so much on anxiety. But when we assessed the anxiety disorders, this was about 10% have an anxiety disorder. And most of the visually impaired patients would have agoraphobia, so they're afraid to go outside, or a panic disorder. We also assessed if these patients perceive a need for mental health care. Because you may invent a nice new program, but maybe no one wants it. So we just want to know if this would be accepted by patients. And about half of the patient group said they had no need. And I found it striking that there was 28% who said not to have a need had subspecial symptoms or disorders. On the other hand, almost 20% said their needs were met, so they had care that was enough for them. And about a quarter said they were in need of additional help, additional mental help. And again, this was 30% of the patients without symptoms said they had a need in mental health care. So this is also something to think about. The type of care they need, a quarter said they needed practical support, information, skills training, counseling, a referral, for example, to a general practitioner, to a psychiatrist, and 3% said they needed medication for their depression or anxiety problems. We also wanted to know who are really in need. And we found that, well, forget the table, I'll just tell you the results. People who had depression and anxiety symptoms, they were more often in need than people without these symptoms. We also found that people with a higher age would more often say that they do not have a need or that their needs were met. Patients with a low health status would more often say that they are in need of mental health care. We also asked for reasons for not receiving enough care. Some people said, well, I didn't know where to get extra help. Others said, I'd rather solve it myself, or I'm on a waiting list. I asked for it, but I didn't get it. I'm still on the treatment, which may be positive because they are kind of in a good direction. 5% said, I thought this wouldn't help, or I was afraid to ask for help because of a stigma, what would others think about that? Some people said I already had help in another way, or I didn't have enough money. So, this is the last 2-3 slides, I guess. I think that although there's more attention, at least in the literature, depression and anxiety among visually impaired older adults is still problematic. And I think it's an urgent problem because we're getting many more older adults in our societies. And in many patients, problems are severe or may become severe. Associated factors are partly solved by, can be partly solved by rehabilitation interventions. And we also saw that many patients still perceive the need. Some don't perceive the need, even if their symptoms or disorders are present. So what should we do? We know that the mild symptoms are the most important predictors of disorders. What should we do? Should we start screening all our visually impaired patients? Should we improve recognition and awareness among the professionals? And I think we need to take a look at our interventions or develop interventions that are aimed directly at reducing symptoms, depressive or anxiety symptoms, or the associated factors such as coping, acceptance, and activities of daily life. So if you don't have that in your country, I think it's a good reason to develop something. And I think STEP care and collaborative or multidisciplinary care are promising ways to improve the situation for depressed and anxious, visually impaired older adults. So I'd like to acknowledge my team. On the left you see the two Hildes. They're both called Hilde. The first one is doing the STEP care study, this woman. She's doing a study in dual sensory loss, but she also helped me with the depression study in the Netherlands and Belgium. Mirka just analyzed the perceived need data. She's Hani Gomez, she's an associate professor in the psychiatric department, and on the right it's my boss, Ger van Rens, who is an ophthalmologist and who's leading the low vision research at our department. And I'd also like to acknowledge the rehabilitation centers and funding institutions, Visio Bartimeus, Licht en Liefde, Zonneweg, and Blind Help Federation. And last but not least, I'd like to acknowledge the participants in our studies. Thank you. That was a lot, wasn't it?
Very interesting.
Some question?
Yeah. Right?
Hi, well, congratulations on a really excellent presentation. It was so informative. I have a million questions, but I'll ask you both later. One question I want to know is, you said 4% said they didn't ask for help due to stigma. Now, to me that seems very low unless depression does not have a stigma in the Netherlands. In Ireland and in the UK, there is a big stigma associated with saying you're depressed, it affects your employment prospects. There's lots of problems with that. Do you think there's a less stigma in the Netherlands?
I don't think so, actually. So you're right, it might be a bit low. I'm not sure why it is. Maybe because the patients are already in a care process, because we invited them at the rehabilitation centers when they entered the center, so they're already active in finding help. So it might have something to do with that. Yes, please.
Yes, it was really interesting and lots of questions
Thank you.
aroused me. You mentioned 16% had anxiety, depression disorders, and the majority had agoraphobia, as you mentioned. And do you know how many of these persons have already taken basically rehabilitation, like orientation, mobility training? Because you don't know.
I'm not sure. Well, it's a combined group. So in Belgium, for example, which is part of the population, people are in care, and yes, we invited them in a different way. So these were not new patients. So it could be that these patients were trained. In the Netherlands, there were more patients that were new in the organizations. So they might not have had any other rehabilitation, but I'm not sure about that.
Thank you very much.
One other question, not concerning maybe subject, but I wonder if you, with respect to independent variables, do you have any questions about their sexual life? I think it is very important from their viewpoint of depression.
Yes, could be. I didn't think of doing that, but
Why not? Private, something like that, or?
maybe we asked some other intimate details, such as if someone would have youth trauma, and this would involve also sexual harassment, for example, but in which happened in youth.
Not like trauma, like ongoing
Yes,
process.
I understand. Yeah, no,
I think this is important.
of that. Could be. Yes.
Excuse me, just one more.
If you don't mind, we
Yeah.
just go to the next.
Yes.
I was wondering, in the first study you mentioned, the longitudinal one,
Yes.
were the elderly people who were depressed, did they show symptoms of depression in their youth? I mean, was it a progressional thing or?
No, I haven't looked at that. I wouldn't know.
It's very interesting.
Sorry, but you also mentioned that you will look in the next phase of this research how long the therapy lasts. I mean, how many months they will be without the symptoms.
Yes.
And you might consider that especially the AMD and other age-related eye diseases, they are deteriorating. So you have to use it as a variable, how
Yes,
the vision is
you're right. Yes.
distorted.
We don't measure it
Yeah,
by ophthalmologist, for example, but we ask patients if they have deteriorated.
Mhm.
It's not that reliable.
They can tell
but
it.
you
They
have
can.
to
No, they
ask.
can tell it absolutely. They know. They know the best.
Yeah.
Yeah.
Another quick one. Were they acquired sight loss, or were they a mixture of people who had long-term sight loss, the old people in your study, the ones at the moment? Were they people who were newly diagnosed with sight loss? You know?
No.
You don't know?
No, I don't think so.
Okay.
No.
And it's very interesting. You said that there were a number. I can't remember the percentage of those who showed no symptoms on the depressive disorder scale, on the symptom scale. But yet they thought they needed help. What would you say about that? You mentioned that there were a number of people in that who thought they needed some help, but actually they didn't seem to show it on the.
Let's see. So the ones who needed help.
No, they actually didn't need help. I think when you asked them, they said they had they did have need, but when you did the scale, the check with them, they didn't have the need.
Yes.
Yeah.
Yeah.
Does that make sense?
Well, we asked them if they perceive the need
Yes.
For mental health care in different areas.
Okay.
So if one would have a need for information, for example, or others for counseling, then we would say this person would have a need. This person would be in need.
Okay.
Yeah.
It wasn't based on the scale that you did the.
No.
Okay.
No.
All right.
It was just descriptive questions. Yeah. Okay. Thank you very much.
Thank you very much for the quality of your communication. It's exactly the kind of knowledge that we need on our database because it can help us in our daily work as a services provider to find a new way